I would now like to use the Gibbs model of self-reflection to talk about the numerous scenarios we've been presented during the semester. First of all, I wanted to talk about a patient who is conscious and presenting with chest pain. The first step involves describing what happened. The couple of times we had this scenario during the semester, walked into the patient and being told that their name's so and so, and just have a bit of chest pain. So initially presenting as just a regular chest pain case. Sitting in a chair, talking to me properly, so I was obviously getting a good response. So following the primary survey, walked in and began my assessment. Because at the time we had been learning a lot about cardiac arrests and a lot of the serious consequences about what can happen, I was feeling a bit uneasy about this, as this time was my first chest pain case. So I was automatically going in my head and thinking about the worst case scenario and what type of form of acute coronary syndrome it could be. And so I think that I was already thinking the worst case scenario due to the content in the lecture rather than focusing on the case as such. I still managed, when trying to gather information from the patient, I did manage to gain a fairly structured approach, which was still good. So drawing on the fundamentals of your primary survey, Dr. ABCH, and going through them, and then moving into a structured approach with Dolo and Ample, I was still able to obtain some fairly good information. But at the time I was struggling with taking that information in and drawing upon the bigger pictures and bigger concepts and trying to understand what was actually happening. I had a fairly good knowledge on the basics and what it meant for each individual form of acute coronary syndrome, but like I said, wasn't able at that stage or comfortably ready to look at the big picture and try and get a basic understanding of what was happening with this patient rather than just remembering symptoms. I think what I could have done, I could certainly have done some active listening and more repeating of what the patient says, so in a way that, let me clarify, you were sitting at home watching TV when this came on, started, blah, blah, blah. So actually verbalize back to the patient just to confirm to myself what was right. So I think that would have been a much better approach for me to use because I was asking the right questions. I just really wasn't appropriately listening to the answers. The knowledge of the precautions and indications for aspirin and GTN in particular, not so much for pain relief, for morphine. I could have known a lot better. So that struggled because that was something I had to actively think about during the first couple of times with this scenario rather than just being able to roll it off the top of the tongue and actually knowing it off by heart perfectly. If the same situation was to arise again, or if I was to go into a chest pain scenario now, I certainly would feel a lot more confident. There's a few things I would specifically do to improve my management of the situation. First of all, wouldn't go in with any expectations. I think the first couple of times I was expecting to be stressed and to expect the worst as well because of what we had been covering in the lectures. So, like I said, if I was to go in now, I would be a lot more judgmental purely based on the situation rather than any previous knowledge. I think right now, if I was to do another one, or in the last couple of ones that we did, I was feeling a lot more calm and a lot more confident in my ability to know the indications and know the contraindications for all drugs involved, whether it's aspirin, GTN, whether it's the patch, and the differentiating between the use of the two, as well as when pain management and pain relief is appropriate. I would still use the same structured approach, such as your Dolo, your Ample, after obviously following a primary survey and standard precautions. I feel that, like I said last time, the first couple of times I was still able to gather some quite good information and a good picture of what had happened, but wasn't able to reaffirm that to myself, so I would actively listen and repeating back to the patient like I was talking about before, just to confirm it in my mind more than anything. So I think, like I said, in a lot of ways it's just getting that approach more structured. So walk in, changes your primary survey, dollar or ample, get some good information, some good past history taking, being sure to ask the right questions. Don't use open-ended questions and don't do leading questions. Don't give them the right answers. Get them to physically point where it is, and that's a really good indication of whether it's the entire chest or whether they can actually pinpoint it. Does it hurt on inspiration? All those things of asking the right questions to get the right answers. I think I'm a lot more confident now, and I would certainly do differently rather than the first couple of times. And really separating that step, that it's like any other thing. You have your primary approach, you gather your information, obviously taking vital signs in the first place, and being sure to monitor them again after any form of treatment. Make an initial assessment, so what type of medications they would need. Do they need aspirin? Do they need GTN? Is it cardiac? Is it pleuritic? Is it traumatic? Using that good basis of knowledge that this unit's instilled in me to then make a primary decision and go with that.